Welcome to the Primi Chats, and thank you so much for joining us here today. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation, or CPBF. We are a charitable organization, and our mission is to empower families of premature babies through support and education. This Primi Chat series is one of the many initiatives we have to bring information for NICU families and healthcare professionals. Here every Friday, we talk with experts, researchers, and parents who share with us the experience and knowledge. Also on our website, canadianpremis.org, there you'll find all kinds of resources and support. And one of them is the Parent Care Program. CPBF is offering 4 free therapy sessions for families who are currently in the NICU and those who have been discharged up to 3 years. To apply for the Parent Care Program, you can go to our website again, which is the canadianpremis.org. And today we are going to introduce you to the iInteract North, a novel virtual intervention to empower NICU families in the early school years. In this presentation, Dr. Williams will describe the journey of the iInteract North, a virtual parent support program designed with and for parents of children with neonatal medical conditions impacting brain development. She will illustrate the value of patient-oriented research partnerships, strategies, and next steps in wider-scale children's mental health program scalability. And I have here joining me live from Toronto, Dr. Tricia Williams, who is a clinical neuropsychologist and health clinician scientist at SickKids in the Division of Neurology. In her clinical role, she leads the neonatal neuropsychological services for assessment and consultation for children and families following neonatal brain injury and associated medical conditions. Dr. Williams also provides families ongoing consultation. As a health clinician scientist, co-director of the Neuro Outcomes Lab, and co-chair of the Neuro Outcomes Family Advisory Committee, her research focuses on neuropsychological outcomes following early brain injury and the importance of supporting the family in optimizing resilience. She is the principal investigator of the iInteract North project and the Parent Experiences project. Together with a multidisciplinary team, a strong group of students and research staff, Dr. Williams' research program aims to learn more about modifiable factors promoting resilience following early brain injury and to identify models of service delivery that will optimize neuropsychological outcomes. Dr. Williams, thank you so much for joining us here today. I'm so excited about this session and I want to learn more about your program.
Wonderful. Thank you so much for that lovely introduction, and Fabiana, and for asking me to be here today to be with this group. I am so excited to introduce to you the iInteract North program. Today, I am going to share its journey from the very beginning through adaptations and where we are now. And I want to reflect and say a huge thank you to all the parents that have been a part of this iInteract North journey, from participants to our stakeholders and our patient partners who sit down, with us and really helped us get where we are now. I sincerely hope that I do our story justice here today.
I'm sure you will. And for all of you watching us live today, please do send your comments, your questions, your insights, and we're going to address them at the end of her presentation. Dr. Williams, the floor is yours.
Wonderful. Thank you. I'm going to get started and with our first slide. So as Fabiana introduced me, I'm a clinical neuropsychologist, and I've had the privilege of working with children and families with many different types of medical conditions that impact brain development. I currently work in the neonatal neurology services at SickKids, and the families and children I get to meet, often have early experiences. They are children born extremely preterm, children with congenital conditions like congenital heart disease that we know impacts both heart and brain development, as well as children with brain injury at or around the time of birth, like neonatal stroke and hypoxic ischemic encephalopathy. For children following these paths and their families, the follow-up often emphasizes assessment. So if anyone who's been a part of a neonatal follow-up program, there's often assessment and consultation at 12 months, 18 months, and at 36 months of age. Then children transition at Sick Kids to my care as a neuropsychologist in a readiness for a school transition-based assessment around the age of 4 and 5, and then key developmental transitions, often around school transitions and then transitions into young adulthood. We know there have been dramatic improvements in the medical outcomes of these young children who went through so much medical vulnerability at an early age. Yet we know that there's still an impact in terms of that child's neuropsychological development and their mental health. In our early patient priority work, we heard from families and the call for us as practitioners and clinicians to see this as more than a medical condition. Many families, parents reflected on the invisibility of these type of disabilities, particularly when the condition or the brain injury impacted the child at such a young age. Many of our children have all of these assessments, yet we know that there's this learning toll and psychosocial toll, and it's these issues that families call us to prioritize in our work. In our early work, we documented as high as 40% of children had one or more mental health related diagnoses, like a learning disability or anxiety. We also saw a lot of children with secondary attention and behavior concerns in the early years. Sometimes they were diagnosed with ADHD. What we heard from these families and we saw in their follow-up data was that these children were at a particular risk for negative school outcomes in terms of not being able to keep up with the curriculum or their attention and behavior getting in the way of engaging at school, engaging with friends, but also engaging as a family and causing considerable distress in the home. All of this led to our initial parent experience study. In this patient-oriented research design study, we sat down with stakeholders from our neonatal follow-up program and asked parents to help us design a questionnaire that would incorporate outcomes that mattered to parents. And many parents reflected on the importance of asking about mental health for their child, but also importantly for the parent. One parent reflected how difficult it was to ask for help for themselves as a parent, when so often in medical care we emphasize and really prioritize the child's well-being and not consider the parent who's raising that child. When we used that questionnaire that was co-designed among a larger group of families, graduates from our neonatal follow-up program, parents identified the following needs. Some programs that might help them develop better parenting skills and confidence. There's a strong prioritization on the importance of social emotional functioning as an indicator of resilience. Parents also reflected on the need and the desire to understand at a deeper level the impact of that child's early condition or the early brain injury on the later neurocognitive, learning, and social emotional well-being. Now, this study was completed prior to the pandemic, but I think probably all on the call can identify with the barriers that get in the way of accessing support for children and support for families, particularly in medically complex cases where there's maybe other meetings and other visits that need to be coordinated. One barrier I wanted to highlight with this group today was the lack of fit that many families described when referred to traditional evidence-based community parenting support and mental health programs. They reflected how they didn't feel that the therapist or the approach helped them understand or understood and took into account the impact of raising a child with this early condition that has impacted their brain development and subsequent neurodevelopmental outcomes, but also the impact of raising a child with those concerns and worries on the parent and the family system. All of this culminated in the I Interact North program that I'm introducing here today. Following the mandate of that results from the larger survey looking at patient, parent, stakeholder needs and barriers, we looked to the literature on what programs might be out there that would meet those needs. And we found a program led by Dr. Sherry Wade at Cincinnati Children's Medical Center. And her program was called I Interact. And Dr. Wade has been a leader for the last 2 decades in virtual-based approaches in helping families recover following a child or a youth's traumatic brain injury. So traumatic brain injury are often occurred in older children and adolescents. The most common reason are often falls or motor vehicle accidents. She had developed these programs to help improve positive parenting, the parent-child relationship, and she'd done them all online. So why we chose that program, one, it was obvious it already had evidence of a virtual-based approach, which we had decided prior to the pandemic was novel and got around many of those barriers and the extra burden that extra appointments can be for families. But importantly, Dr. Wade's program included important information that our parents were looking for. What it's like, the information they were looking for in terms of the brain's relationship to early behavior, social, emotional challenges. Dr. Wade generously allowed us to pilot that program, which we did prior to the pandemic with strong results. Then we looked at the feedback from the families that had participated. And we had a transdiagnostic inclusive approach of involving families. So we had families of children born extremely preterm. We had families with children, neonatal stroke, other mechanisms of injury or complex conditions in the neonatal follow-up at sick kids. We used the feedback from this group of families to build I Interact North. We also included a new group of families to tell us about what approach would be meaningful to them. We also looked to our clinical stakeholders, the referral sources at sick kids and in our community for feedback on how to best build a program like I Interact North. And what the major changes were to make it more transdiagnostic inclusive, but also to strongly reflect the parent voice and parent experiences. So you'll see many parent testimonials on the impact of raising a child following these serious events, but also how the family worked with the I Interact North program and adapted it for their family's unique situation. Very briefly, how I Interact North works. The therapeutic mechanism is really about empowering parents, helping them build the skills and feel great as a parent. Because as we know, as parents, sometimes it's the hardest job we're ever going to have. So giving the parents lots of support and encouragement and some key sort of simple strategies to build on responsivity, predictability, and consistency in the home, which we know are long-standing sort of kernels of optimizing a child's well-being. We deliver the program in 7 learning modules online that the parents review. Then, after they've reviewed a learning module, they meet with a coach. And this is where I would joke that the magic happens. So the therapist can, or the family can talk about what they learned in the module, and the therapist can help them if there's any questions, but also most importantly to adapt and make it specific to that family's situation. Then there's actually even live coaching where we look at the parent and the child who are playing together, and we give the parents strategies on how to actually promote that positivity and responsivity with their child directly in play. All of it has always been delivered virtually, and it actually is pretty natural, and families have reflected on how lovely it is, not just from a convenience perspective, but to practice some of these skills in the actual environment in which you are living every day. Now, given our program was already virtual prior to the pandemic, in 2020, we were able to seamlessly pivot, and we expanded our outreach and referral sources beyond neonatal neurology to general neurology, including children and families with epilepsy. We also included families across a division of psychology and psychiatry at Sick Kids. And even across that year of collection of data, we were able to document that this program worked to improve concerns about children's behavior in the home at a time where we knew was increased stress. And as shown here in red, parents reflected on the improvements and the intensity of the problems they were seeing in the home, as well as the total number of problems. One family reflected on how amazed they were that these simple activities could really change the relationship that they had with their child. However, 2020 was a tumultuous year, and there was many additional barriers that families reflected on in participating in the traditional sort of one-size-7 session program. So we all know we were spending lots of time online, and our children were too. So adding an additional Zoom session to the evening or the weekend was not necessarily something as attractive as it might have been pre-COVID. So we took that information and we developed a stepped care approach to providing parenting support. We partnered with the province of Ontario's neurodevelopmental network to also reach additional vulnerable families during the second year of the pandemic in 2021. So the PON network includes children and families with children with ADHD and autism, who we also knew were at increased risk for mental health concerns during the pandemic. Very simply, stepped care is an approach that tailors the intervention to the family's needs, starting from the least intensive sort of intervention to the most intensive. Informed by our family advisory group, as well as the families who completed the program, we developed this stepped approach. And the psychoeducation podcast, which is the least intensive, where the families review a podcast, really outlining simple positive parenting strategies, talking about the realities and compassion needed for parents during the pandemic. And I want to credit the podcast to a direct suggestion one of our family advisory committee members came to us with. This individual told us, don't send us to another website or give us another handout. We want something live that I can listen to when I'm maybe making dinner or I'm driving to something else. So that's really was informed by that input. Then, based on need, the concerns about the child's behavior, parenting stress, COVID-specific stress, parents and families are graduated to an abbreviated positive parenting coaching, 2 sessions where the introduction and initial practice of these skills is offered. Then at the end of session 2, there's a collaborative discussion where the parent and the therapist review their progress to date and discuss the needs of the family and the realities of committing to a longer extended program. Now, although we are still analyzing the data from 2021 and we just closed recruitment at the in March of this year, the data from a feasibility and acceptability perspective has been positive. And I was personally pleased when we could document that there's increase in skill even with the abbreviated approach at step 2, as shown here, and an increase in positive parenting observed within the therapy session. And therapists also reflected on the benefits of how the therapist can work with the family to help them adapt to that child and their family's unique situation. Our next steps are how to leverage and learn from our stepped care experience during COVID to bring this program to more families across Ontario and hopefully with the ultimate goal across Canada. I hope in the story today you have heard how we have prioritized parents' voices at every step in our journey, from the initial planning to adaptation, and now as we move into more of an implementation stage in our work, how parents' voices are integral in making this work and come to other families in need. I sincerely hope that our next steps can move towards a more seamless model of follow-up from our neonatal follow-up, our NICU families, so that we can move from not just assessing concerns in the early years, but really truly committing to addressing them. Thank you so much for the time. I'm really excited to talk with you and welcome questions. Thank you. And this is a picture of my lovely group of family advisors at one of our meetings this year. Thank you.
Dr. Williams, thank you so much. Wow, it's amazing to see your whole team and a lot of families involved in your project. So congratulations on that, because I know it takes a lot of courage to involve families, because not always you hear the you hear what you want to hear, but the fact that you work with families and you create such a successful program, it is really incredible. I'm going to open here with a comment from Josette. Josette, thank you so much for joining us here today. She said, as I reflect on our past journey, I wish there were programs and follow-ups beyond the 5-year follow-up. This is challenging for parents of preemies to manage and have a direction where to find help. Even asking for help within the medical and educational system, they are not educated on brain health, especially premature brains. I'm very happy to see there is a start to this important issue for preemies. Thank you. Absolutely. I can only say I agree, and I wish I also had that on my first few years.
Yeah, I say thank you so much, Josette, for that comment. I'm truly committed. I think iInteract North is one of, I hope, many sort of interventions and strategies that can come from the work that we're doing in our lab. You reflected on in your comment the education system, and we've started to work with teachers in terms of some parallels that can be made in terms of the approaches that when families are in our program, it could also be mirrored in the school. And also empowering parents. My family advisory group met this past Monday, and plans for moving forward, and just even the lingo and readiness for school and all of the advocacy work that often falls to parents, is also on our radar. So thank you so much.
Yeah, and it does create a lot of anxiety for parents to take that next step into the educational system. So, doctors, a question for you about the learning modules. How did you create the learning modules, and what is the curriculum behind those learning modules? Because one comment that you made is like parents do not, they feel that the traditional mental health services do not understand their needs. So this curriculum was developed with parents?
Mm-hmm. So this curriculum was adapted, and you can see seeds of many of the positive parenting programs that are available to general community, like the Triple P program, parent-child interaction therapy, as well as the early years parenting program. So you'll see the curriculum follows many of the kind of positive parenting. For example, like initial sessions are on, how do you actually look for positive behaviors in your children and try to ignore some of the ones that are maybe more bothersome, but if you ignore them, they'll actually extinguish easier than if you pay more attention to them. So that's a common positive parenting curriculum item that is in our initial sessions. But the extension on that, and sort of including parents and the reality that we know as neuropsychologists, is that children with these early life experiences may need slightly, they may need a little extra time, or they may sort of understanding how that impacts. So that's where the curriculum is adapted from parent voices, but also what we know in terms of some of the neuropsychological outcomes. If a child is maybe more readily upset or inattentive, they may need a slightly different or adapted approach.
Okay, I think my next question is in regards to the siblings, because you knew I was going to go, because I think we had discussed that. Because if my child has a brain injury, and we have all those behavior issues, and mom and dad or the parents are very focused on that child, and you have to address all that is going on, and the siblings left aside. So I feel the parents also need strategies for the siblings, and we always talk about that. How do we manage with the siblings, so the siblings still involved, they still feel that it's part of the family, and not always left aside or deal with the anxiety? So do we address that in this program?
Yes. So you address the sibling issue in terms of this program, and I think we've had a lot of families reflect on how it has not just worked with the identified patient child, it can work with the siblings. And we always encourage, obviously, if you're practicing good positive parenting and predictability through the home, you're going to have that uniform approach with all of the children in your home, and you're going to see a positive benefit and improved quality of life in your family. So that can be, there's definitely, and we try, and the siblings are actually included in some of the sessions just practically because they're in the home. If there's behavior concerns in the sibling, again, the same approaches are going to work. So what I like to sort of see this program is be able to be flexible enough, is sometimes we actually have families try to get into the program when the concern is the sibling. And maybe it's because the sibling is reacting to maybe the attention given to the identified patient child. But regardless of sort of why, it's sort of, maybe it's having that flexibility, I think, in a research program sometimes isn't always there, but it would be lovely to extend this when the concern is actually the sibling. But then we talked, I think, Fabiana, we've talked about sometimes, the positive attention that you're giving to one, making sure it's equal. And that also can set and recalibrate in some ways some of these stresses and tensions that can occur and impact on siblings.
Yeah, so that is so important. So you talk a lot about the virtual being already set up before the pandemic. With the pandemic, it's like, okay, this is the natural thing to do. This is what we have to do. Let's talk about the benefits of having those virtual sessions, because as we know, a lot of families in Canada have to travel long distances to come to main centers for appointments and therapies. specialist appointments, and this is not one more appointment they have to travel to. So was that one of the benefits, and what else have you seen in terms of benefits for parents to do this virtually?
Yeah, I mean, you've listed sort of one of the biggest benefits and joys, I think, and families just love that, they joke like, we come into their room, like we're really in their home. And I think that's a huge benefit and really breaks down some, not all, but of the barriers to mental health service. We've also been able to sort of provide, when needed, sort of devices as part of our research program to get around some of the more economic. Another benefit of this program, I think, as I alluded in the presentation, is the validity of actually practicing the skills that you want to maintain in the natural environment that you're actually day-to-day as a parent, versus coming to my office, where maybe sometimes I've heard children are on maybe better behavior or worse behavior. So you're actually seeing, live tantrums or live triggers, and siblings sometimes are one of them, or turning the screens off. And you're really, that validity of the approach, I think, is a real strength of this program. And I think, we kind of become a little bit more familiar and less formal. I think the pandemic did that a little bit, but also this approach does. And we've been some kids even call us like Siri, like we're just like, or we're Alexa in the background, because it's just there. So I hope it's breaking down also the stigma of getting this kind of support.
Wow, that is great. For people who want to start something similar, what are the considerations to start such a program?
I think there's a couple of really important considerations, and we followed really a knowledge to action framework, really listened to the needs of our families. And that was from the outset, in designing the parent experience questionnaire and then surveying a questionnaire. I think in designing a program, it's also really important not to reinvent the wheel. We have a lot of information on, say, for example, positive parenting in the home across many different conditions. And so, adapting some key core elements of evidence-based programs, because, starting something from scratch without sort of theory behind it may not be as impactful on what you're trying to actually treat. But then, of course, looking at the adaptable components like that, I hope I've illustrated on how we can personalize it for unique families as we meet them. And I think, it's easier to sort of cluster under diagnoses or experiences, but every family is very unique. And a program like this is sort of, how can we adapt, but still retain those nuggets of sort of the therapeutic piece, make it more precise for the families by sort of including more voices and experientials from other families.
Okay, so how are we measuring the success of this program with parents?
Okay, we measured in a number of different ways. I can tell you my favorites, but the ones that we apply for funding, we obviously look at the effect size that I illustrated in some of the diagrams shown in the presentation. We look at sort of like changes in the parenting skills. And so going from very, the interactions they have with their child that maybe aren't as positive, to seeing that improvement. So that's one that we use objective ratings of that. We also ask for the parents' feedback on how, and that was one of the other graphs to show like, yes, this program can improve outcomes. And then maybe my more favorite ones, which are the ones we kind of start with always and keep on top of mind, is how feasible is this and how acceptable is it to our families? So that can be in terms of monitoring, families and reasons why they can or cannot complete the whole program. But, and then kind of getting to my favorite really is listening to families and the qualitative approaches, and we interview our families after they're done and get that feedback. And so we're constantly sort of in iterations, we're not changing it every week, but that responsibility to think and adapt, I've shown over a course of years through the pandemic, and now we're kind of moving forward, that those are the ways that all of those outcomes, all from feasibility, acceptability, the parents' voices, and actual impact on child behavior and family functioning, really combine in terms of moving this program forward.
It's wonderful. Dr. Ruiz, share with us some of the things that parents are saying to you, because you did address that on your presentation, that parents do not address their own needs when they have a child with brain injury. And I can certainly say that because my child has a brain injury and I did not address my needs for a very long time, which is very detrimental for me as a parent, for my family, how I'm raising my children. And one of the things that nobody really asked how I was doing. So I didn't take that time to check on me, how I was doing, because there was not a question that was asked me for such a long time. And you did talk about that on your presentation. So, and having this program now to address the parents' needs and give them tools and some other skills, what are you hearing from them?
One of my favorite quotes is, "I wish I had this sooner." I wish, this, and I've also heard this is applicable to everyone. This should be accessible to, like, someone said this should be a high school course that we learn, because no one really gives that training for parents. We've also heard in terms of like how impactful it has been in terms of resetting, and sometimes that stress, and sometimes cycles of negativity can happen in a stressed household, and it's understandable. And I think, Fabiana, thank you for sharing your history. That self-compassion that's needed to increase the parents' wellness. And even though that's not a formal part of our program, because we have the therapist coach, I think that is that time to debrief and reflect on the importance of the parents' well-being, because we often think of our children first, right? And not ourselves. And that kind of helping, as you said, it's actually in our child's best interest to take care of ourselves. So, these are some of the things we reflected on, and really, I guess, motivate us to continue championing this program so we can keep it available to families and hopefully expand it to others.
Okay, so let's talk about expand to others, because it's such a great program. I don't think you need much more evidence to show the success, and how can people take this on and really support the community. So what are the steps that you are going to take to make sure you disseminate this knowledge across Canada, and not only stays at Sick Kids or in Ontario? Because I feel every family should have access to this.
Yes, well, that is the dream, the goal, and we've only been working on this 3 years, so I kind of want to give us like, okay, but we're on the way, and it's lovely meetings with you and this group that help reassure that we are on the right path. The next steps for us, we were fortunate to have a 1-year CHR grant. And the last phase of that grant is we're going to be entering into a co-design phase and bringing in some stakeholders from at least the Ontario community, and hopefully ministry members, and really start to sort of sit down and how can this be embedded in a clinical care pathway. I'm also seeking other funds and collaborations to really test out a clinical care pathway and look at the implementation on how could it be referred centrally, whether it be centrally back. This is a virtual program. One of the things that maybe Sick Kids becomes a hub, but we really have to work on that knowledge mobilization efforts and translation to make sure people are aware of it. And that is something sort of engaging with knowledge mobilization experts. And we are in that process for our next steps to make sure we can build different spokes across key centers to get the message out to families that this program is available to them. And then the last piece too that we're working on, I guess, is also, can this program even become more precise? How can we help people on the pathway of this program? And that's sort of a new initiative in terms of aligned with precision child mental health.
That is wonderful. And you can certainly count on the Canadian Premature Babies Foundation to disseminate and be part of your knowledge mobilization, because I think every family who experiences an ICU certainly could have access and should have access to such a program. Dr. Willis, thank you so much for joining us here today. Such a pleasure talking to you, learning from you, and congratulations on this project. It's really, really amazing.
Thank you so much on behalf of my entire team for having us here today.
Thank you. And to all of you watching us live today on Twitter, Facebook, or YouTube, thank you so much for joining us. And the video of today's session and all the videos from our live series are available on our website, which is the canadianpremis.org. And I want to thank our sponsor, AstraZeneca, for their ongoing support of our education sessions. And we are a charitable organization, and we believe that through support and education, we can empower families, ensuring they are ready to care for their babies. Please visit our website, consider making a donation. Together, we can create a brighter future for all our families. And I see you again next Friday, 1 p.m. Eastern Time. Stay well.